USMLE ophthalmology questions demand rapid triage. Success hinges on mapping the patient's chief complaint, specifically changes in visual acuity, the presence of pain, and laterality, directly to a distinct endpoint. If you examine a child and see an abnormal corneal light reflex, that dictates an immediate evaluation for strabismus. If you observe an asymmetric or distinctly white red reflex, you must immediately rule out retinoblastoma. When a patient presents with bilateral eye pain hours after severe ultraviolet exposure, the diagnosis is photokeratitis. If the patient describes a transient monocular blindness lasting only seconds to minutes, you are looking at amaurosis fugax. By contrast, sudden, painless, and persistent vision loss points directly to a central retinal artery or vein occlusion. The specific triad of new floaters, flashing lights, and a curtain-like deficit in the visual field confirms a retinal detachment. If the vision is hazy and red, and a fundus is obscured on examination, there is a vitreous hemorrhage, and complaints of progressive night blindness are the hallmark of retinitis pigmentosa. Internalizing this presentation matrix establishes the diagnostic threshold needed to isolate the correct pathology before considering the next management step. In pediatric patients, screening is a preventative necessity. Vision must be checked at every well-child visit until age 5 to prevent permanent amblyopia. You diagnose strabismus when you observe constant eye deviation, asymmetric corneal light reflexes, and abnormal results on the cover test. The management pathway prioritizes correcting any refractive errors first. From there, you strengthen the deviated eye by patching or using cycloplegic drops to blur the unaffected eye. This outlines the normal and abnormal red reflex. Notice the healthy, symmetrical red reflex on top. On the bottom right, an abnormal white reflex, known as leukocoria. Retinoblastoma frequently presents as leukocoria. Investigating this requires an immediate dilated fundoscopic exam. The primary predictor for metastatic disease in these patients is the extent of optic nerve invasion. Failing to investigate a new-onset pediatric strabismus for an underlying white reflex risks missing a highly metastatic malignancy. Moving from pediatric screening to environmental injuries, certain pathologies cluster in high-altitude environments, snowfields, or near water. Photokeratitis occurs when ultraviolet light radiation physically strips away the outermost cellular layer of the corneal epithelium. Symptoms do not appear immediately. Patients develop severe bilateral eye pain, photophobia, and a foreign body sensation roughly 6 to 12 hours after the exposure. On physical exam, applying fluorescein dye to the eye will reveal punctate corneal staining. Management is entirely supportive. You prescribe oral analgesics and topical antibiotic prophylaxis as the symptoms naturally resolve within 1 to 3 days. The strictly bilateral presentation and the specific 6 to 12-hour delayed onset differentiate this environmental UV damage from unilateral infectious keratitis or acute physical trauma. This reference table breaks down the differential diagnosis for acute, painless, monocular vision loss. We will focus on the top 2 rows to separate arterial from venous occlusion. Central retinal artery occlusion, or CRAO, presents as sudden, severe vision loss. It is frequently preceded by amaurosis fugax in patients with known embolic risk factors. A fundoscopic exam of a CRAO reveals diffuse ischemic retinal whitening, paired with a distinct cherry red spot at the macula. This is an emergency requiring immediate intervention. Management prioritizes ocular massage and the rapid reduction of intraocular pressure via anterior chamber paracentesis to dislodge the clot. Central retinal vein occlusion, or CRVO, presents differently. The onset of vision loss is less abrupt, and the severity varies from patient to patient. This fundoscopic image shows the diagnostic features of CRVO. The backup of blood causes extensive, chaotic retinal hemorrhages, tortuous vessels, cotton wool spots, and optic disc edema. Because this is venous congestion rather than an arterial blockage, management is conservative. It relies on observation and potentially intravitreal injections of VEGF-EFS inhibitors. The underlying vascular mechanism dictates your exact triage path. You either perform immediate mechanical intervention to dislodge an arterial clot, or you observe and medicate venous congestion. Acute vision changes can also result from mechanical intraocular disruptions. These often share the initial symptom of sudden onset floaters. A retinal detachment presents with new floaters, flashing lights, and a progressive visual defect described as a dark curtain falling over the vision. A detached retina requires definitive surgical correction, usually through retinopexy or vitrectomy. A vitreous hemorrhage also presents with sudden floaters, but it typically lacks the flashing lights seen in retinal detachment. On physical exam, a vitreous hemorrhage creates a hazy red hue. The floating debris of red blood cells will physically obscure the physician's view of the fundus. The immediate next steps for a vitreous hemorrhage are ordering an ophthalmology consult and elevating the head of the patient's bed 30 to 45 degrees to let the blood settle. An obscured fundus indicates active bleeding into the vitreous space. A visible elevated fundus paired with a curtain-like visual field loss confirms a structural detachment. Acute emergencies require rapid intervention, but chronic disease states cause a slow, progressive visual loss over time. Retinitis pigmentosa is driven by a steady, progressive destruction of the eye's photoreceptor cells. The clinical progression begins with early-stage night blindness. Over time, this advances to a severe loss of the mid-peripheral visual field, leaving only a narrow tunnel of central vision. Physical exam markers include retinal vessel attenuation and optic disc pallor. Left unchecked, this progression leads to midlife legal blindness. Diabetes also severely impacts the eye. Systemic hyperglycemia can directly alter the lens, causing transient, rapid-onset refractive changes. The severe chronic ocular complications of diabetes include early-onset cataracts, glaucoma, and macular edema. Diabetic retinopathy progresses predictably. It begins in a non-proliferative state characterized by microaneurysms and advances to a proliferative state defined by neovascularization arising from the disc. Chronic visual deterioration demands aggressive systemic management. These localized ocular findings are downstream indicators of irreversible systemic pathology.